Hello students, I'm going to provide you the lecture for week 1, day 2. Our concept now is leadership, and our first exemplar, which is an example of that concept, is the nursing process. So we're going to begin this lecture with letting you look and review a video from Pearson on the nursing process.
Every day in patient care. The nursing process is a framework that enables nurses to create care plans and to look at what has been done, what should continue to be done, and what needs to be changed to assist patients to a state of well-being.
The nursing process is usually described as having these steps. Assessment, nursing diagnosis, planning. Some schools include outcome identification as a separate step after the planning phase, implementation or nursing interventions, and evaluation. You all are CPR certified and therefore have been instructed in the use of an automated external defibrillator or AED. Since this material is familiar to you, we will look at the nursing process in terms of deciding to use an AED. What is the first thing you would do if you were walking a patient down the hall and the patient falls to the ground? Right. Assess the patient. What would you assess for? What do AED guidelines say to assess? Let's check this video to see if we are doing it right. You assess the patient to see if he is okay. Based on your assessment, he is not. You check circulation first. You find the patient has no pulse.
Code blue!
You quickly think which nursing diagnosis would apply to this patient. The North American Nursing Diagnosis Association, or NANDA International, has a long list of choices, but the logical NANDA diagnosis for a patient with no pulse would be decreased cardiac output. Now you will move to the third step of the nursing process. Planning. The best way to remember planning is to substitute the word goals or outcomes. What is the goal for this patient? The patient has no pulse. So the goal is the patient will have increased cardiac output as evidenced by a strong pulse after emergency intervention. The next step of the nursing process is implementation, also called nursing interventions or nursing actions. Interventions are all the things the nurse does, arranges for, and so on to reach the goal. Watch the video and list all of the interventions that healthcare team members do to help the patient reach this goal. The patient will have a strong pulse after emergency intervention. You may have to watch the video several times to identify all of them.
If a cardiopulmonary arrest is confirmed, turn the automatic external defibrillator power on, and place the adhesive defibrillator pads on the client's bare chest. One pad goes below the left breast, and the second pad goes just below the client's right collarbone on the ribs. The machine will alert the user to pad connection problems and suggest a remedy. The operator's voice and the client's ECG will be recorded on a removable digital data card inside the battery compartment. The recording begins when the power is turned on and continues for a maximum of 30 minutes. The automatic external defibrillator will instruct you to deliver a shock in 4 ways. 1. A voice prompt to deliver a shock. 2. A steady tone. 3. A shock button flashing. 4. A screen prompt to press the shock button. Say, all stand clear. Say, all
No
stand
person
clear.
should be touching the client or
No
the surface
person
they
should
are
be
lying
touching the
on.
client or the
The
surface
client
they are
cannot
lying
be
on.
lying in liquid.
The client cannot be lying in
Allow
liquid.
the automatic external defibrillator
Allow
to
the
analyze
automatic
the heart
external
rhythm.
defibrillator to analyze the heart rhythm.
If another shock is advised, the
If another
automatic
shock is
external
advised,
defibrillator
the
charges
automatic
to prepare for
external
shock delivery.
defibrillator charges to prepare
Check
for
the
shock
monitor
delivery.
to verify that a rhythm is
Check the
either
monitor
sustained
to verify
ventricular
that a rhythm is
tachycardia
either sustained
or ventricular
ventricular
fibrillation,
tachycardia
and
or
that the
ventricular
client does not have a
fibrillation,
pulse.
and that the client does
Clear
not
the
have a
client
pulse.
and press the shock button.
Clear the client
Again,
and press
allow
the
the
shock
automatic
button.
external
Again,
defibrillator
allow
to
the
analyze the
automatic
heart
external
rhythm.
defibrillator to analyze
This
the heart
client is
rhythm.
now in sinus rhythm.
This client
Assess
is
the
now in
client's
sinus
pulse,
rhythm.
blood pressure,
Assess
and
the
breathing
client's
while
pulse,
maintaining the
blood
airway.
pressure, and breathing while maintaining the airway.
Here is a list of the interventions you would
Here is a
perform for
list
this
of the
patient
interventions
with
you would
decreased
perform
cardiac
for this
output.
patient with decreased cardiac output.
If this were not an emergency and you were
If this
writing
were
a care
not an
plan,
emergency
you would
and
list
you were
all
writing
of
a
these
care plan,
interventions for the
you would
patient
list
to
all of
ensure
these
continuity
interventions
of
for the
care.
patient to ensure continuity of care.
The final step of the nursing process is
The final
evaluation.
step of the nursing process is evaluation.
During the evaluation step, you look
During
at
the
or
evaluation
evaluate
step,
all the
you
previous
look
steps
at
of the
or
nursing
evaluate
process.
all the previous steps of the nursing process.
Assess the patient again.
Assess the
Is data
patient
the
again.
same, or is there more or
Is
different
data the
information
same,
to consider?
or is there more or different information
Look
to
at the
consider?
nursing diagnosis.
Look
Does
at the
it still
nursing
apply to
diagnosis.
the patient's condition?
Does it still apply to the patient's
Review
condition?
the plan, goals, and outcomes.
Review the plan, goals,
Have they
and
been
outcomes.
met or not met?
Have they been
Determine
met
whether
or
to
not met?
continue the care plan as
Determine
is or
whether
to
to
make
continue
changes.
the care plan as is or to make
Determine
changes.
which interventions worked and which did
Determine
not.
which interventions worked and which
Consider
did not.
whether the patient's condition has changed.
Consider whether the
care
patient's
plan should
condition has
change,
changed,
or whether
the care
interventions
plan
should be added
change,
or omitted.
or whether interventions should be added or omitted.
Evaluation is also known as reassessment,
Evaluation is
illustrating
also
how
known
the
as
nursing process is
reassessment,
continuous and
illustrating how the
interactive.
nursing process is continuous
It may
and
lead to
interactive.
new findings and further nursing
It may
diagnoses.
lead to new findings and further nursing
in fact,
diagnoses.
in most clinical situations,
In fact,
several nursing
in most
diagnoses
clinical
exist,
situations,
and they
several
must be
nursing
handled in
diagnoses
priority order.
exist, and they must be handled in priority order.
In this case, since the patient is unconscious,
In
we
this
can
case,
continue
since
to
the
apply the
patient is
nursing process
unconscious,
like this.
we can continue to apply the nursing
Assessment.
process like this.
Patient is unresponsive and
Assessment.
unconscious.
Patient is unresponsive
Nursing
and unconscious.
diagnosis.
Nursing
Altered
diagnosis.
tissue perfusion. Cerebral.
Altered tissue perfusion. Cerebral.
Plan, goal, or outcome.
Plan, goal,
The
or
patient
outcome.
will have increased cerebral tissue
The
perfusion
patient will
as
have
evidenced
increased
by a
cerebral
return to
tissue
consciousness.
perfusion, as evidenced by a return to consciousness.
Interventions. Since we already know that
Interventions.
the client has decreased cardiac
Since we
output
already
and
know
the
that
heart
the
is
client
not
has
beating,
decreased
we can
cardiac
judge that
output
the brain
and the
is
heart
being
is not
starved
beating,
of blood.
we can judge that the brain is
Compressions
being
must be
starved of
provided
blood.
to move blood to the brain.
Compressions must be provided to move blood to the brain.
Evaluation. After a cycle of
Evaluation.
compressions, reassess the patient
After
to
a
see
cycle
whether
of
consciousness
compressions,
has returned.
reassess the patient to see whether consciousness has returned.
Let's sum up the steps of the nursing process one more time.
Let's sum up the steps of the nursing
Assess the
process
patient
one more
to
time.
determine if there are any problems.
Assess a patient to determine
Based
if
on
there
those
are any
problems,
problems.
select appropriate nursing diagnoses.
Based on those problems, select appropriate
From there,
nursing
make a
diagnoses.
plan, also known as goals
From
or
there,
outcomes
make a plan,
for each diagnosis.
also known as goals or outcomes
List
for
all
each
the
diagnosis.
actions needed to implement each goal.
List all the
Perform the
actions needed to
interventions.
implement each goal. Perform
Evaluate
the
the patient.
interventions.
When reassessing,
Evaluate
see if the
the
nursing
patient.
diagnoses still
When
apply.
reassessing, see if the nursing
Judge whether the
diagnoses
plan
still
and
apply.
interventions are meeting the goals.
Judge whether the plan and
Change the
interventions are
nursing care
meeting the
plan
goals.
as the patient's needs change.
Change the nursing care plan as the patient's needs change.
The nursing process is a continuous and ongoing method
The
of
nursing
addressing
process
patient
is a
problems and
continuous and
assisting
ongoing
patients
method
to
of
wellness.
addressing patient problems
The
and
nursing
assisting
process
patients to
never
wellness.
stops as long as a patient is
The
receiving
nursing
nursing
process
care.
never stops as long as a patient is receiving nursing care.
Before we review this PowerPoint on the nursing process, I just want to kind of go over some important facts about the nursing process. It is a way in which we can identify a patient's health status and have actual or potential health care problems or needs. This process, the nursing process, did gain legitimacy in 1973, and it is included in the ANA Standards of Nursing Practice. I even remember myself learning about the nursing process when I was in nursing school, which was back in the 1970s. And as you can tell from each of the steps of the nursing process, assessment, diagnosis, planning, implementation, and evaluation, they all rather overlap and kind of are connected to one another. And what's also important to know about the nursing process is that it is very patient-centered. And again, that's one of our CUSIN competencies. It's a way in which we assess and collect data to determine patients' preferences in daily routines and meeting those personal needs to incorporate these in our plan of care. And that's what makes it such a great tool, and really recognizes it as a process in which it is so patient-centered. It's an adaptation of problem-solving, decision-making involved in every phase, and also interpersonal and collaborative type of communication as well. I wanted to kind of talk about somewhat when we make that diagnosis, and I know many of you are thinking, oh wow, we as nurses, we shouldn't be making nursing diagnoses, but really we're talking about a nursing diagnosis. When we make these nursing diagnoses, we use critical thinking skills to cluster the assessment and identify the problems, and that's how we come about to formulate that nursing diagnosis. So I want to kind of go over the difference between a nursing diagnosis versus a medical diagnosis. The nursing diagnosis is basically a statement of nursing judgment and refers to a condition that nurses, by virtue of their education, their experience, and their expertise are licensed to treat. And it really does describe the human response or a patient's physical, socio-cultural, psychological, and spiritual response to an illness for a health condition. Whereas a medical diagnosis is made by a licensed provider such as a physician, also can be made by an advanced practice nurse or a physician assistant, and it refers to the disease process, a specific pathophysiological response. Medical diagnosis does remain the same for as long as the disease process is present, but a nursing diagnosis changes as the patient responses change. And there are different types of nursing diagnosis. There's an actual nursing diagnosis, that is the patient's problem that is present at the time of the nursing assessment. Examples of that would be ineffective breathing patterns, acute pain and anxiety, and that's based on that cluster of associated assessment data, that subjective and objective data that we obtain on our patients. And then we might have a risk nursing diagnosis, which is a clinical judgment that a problem does not exist, but there are the presence of risk factors that indicates that a problem is likely to develop unless we provide nursing interventions. An example of that would be maybe the patient has low white blood cells, so they are at risk for an infection. There's also more of the uncommon types of nursing diagnoses, such as a wellness diagnosis, a health promotion diagnosis, and a syndrome diagnosis. But again, when we're talking about planning, and the video talked about goals and outcomes, they are somewhat synonymous, but here are the exact definitions or the differences between goal and outcome. A goal is more of an observation that we make from a patient's response. An outcome is more to evaluate the patient's response to the plan of care, kind of seeing if it's meeting our goals or patient outcomes. So that's kind of what the difference is, but you will notice in your reading and in your videos that you see those terms somewhat interchangeable. And I also wanted to bring to your attention, as we continue to understand more about the nursing process, I was wondering if this looks somewhat familiar to you, because it kind of is the way in which we develop our concept maps. We kind of follow through with the nursing process. We initially begin the assessment and obtain that cluster of data, our subjective and objective data, and then we go from there to make that nursing diagnosis, and then we do the planning where we provide a goal or patient outcome, and then we provide those nursing interventions, and then we of course evaluate. And again, when we're talking about goals, we also want to provide goals that follow that SMART acronym that we taught you about in Nursing 100, where SMART means specific. SMART means specific goals. The M stands for measurable, A is attainable, R is realistic, and T is timeable. So again, when we're thinking about those goals, we need to keep in mind that they need to be following that particular acronym as well. So I just wanted to kind of go over a little bit additional information in regards to the nursing process. All right, let's go over this nursing process PowerPoint that I have up here on the screen. The first step of the nursing process is assessment, and we learned about assessment in Nursing 100. Gather information about a patient's psychological, physiological, sociological, and spiritual status. It basically is a patient interview. It includes patient, family history, observation, and a physical exam. Next, we move on to diagnosis, where this is where we make a judgment and kind of go over the definition that I gave you in regards to a nursing diagnosis, because this is what we're talking about here. It's a potential or actual health problem. Potential would be at risk for. And some of our patients, because of their high acuity, may have multiple diagnoses. What is the patient having a problem with? For example, is it sleep? Is it nutrition? Is it comfort? Meaning they're experiencing acute chronic pain, mobility, risk for falls, safety. All those things would be considered as to how to develop this nursing diagnosis. Then our next step is planning and goal setting. Patient stated example, by discharge the patient will have a pulse ox of 95% when ambulating. Again, those goals should follow that SMART acronym. Specific, measurable, attainable, realistic, and within a realistic time frame as well. Then lastly is implementation, where we prioritize the patient's needs. We make it very individualized, and we include monitoring, direct care, patient education, and referrals. And this is where we put into play what nursing interventions we want to do for this patient, as well as some of the orders that the healthcare provider has ordered for the patient as well. And then with all this put into play, we will evaluate the situation. Did the patient reach the goal? If not, what else do we do? And is it continuous? Okay, and we continue this as the video stated, as long as the patient continues to have problems. And again, another name for evaluation is a reassessment of the situation. So let's look at this example. Let me get this more centered on the screen. Okay, we have John. He visits his general physician on Monday because he was feeling sick over the weekend. When he is called back from the waiting room, the nurse on staff takes his temperature, heart rate, and blood pressure. She then asks John a series of questions about how he's been feeling. The nurse notes his responses when he says he's been having difficulty breathing and has been feeling very tired. She also sees on John's medical history that he has had some previous problems with his cholesterol levels and blood pressure. John also has a blood sample taken during his doctor's visit. So John is in the office with the nurse, and get this. And so the nurse looks over John's symptoms and notes that his heart rate is higher than average and his blood pressure is elevated. She also considers that he's experienced fatigue and shortness of breath before when his cholesterol levels were very high. The nurse determines that John is experiencing hyperlipidemia, also known as having high levels of fat within the blood, and John's blood tests confirm this hypothesis. The nurse is also concerned that John is at risk for heart disease. Obviously, high cholesterol, especially high LDLs, will put a person at risk for cardiovascular or heart disease. So John returns on Tuesday for a follow-up visit. The nurse sits down with him in a closed room and explains his cholesterol levels and his high blood pressure. She suggests to John that he be put on medication to help lower these numbers and recommends he exercise at least twice a week. The nurse also tells John he should stay away from salty foods and eat less red meat. John agrees with the nurse, and they set up a follow-up appointment 2 weeks later. The nurse reminds John to call if there are any changes in his condition or if he starts to feel worse. So now, example of implementation. John is prescribed the medication and takes it as recommended. 1 week later, he has a day where he feels especially sick and he calls the doctor's office. The nurse explains that the medication could cause nausea as a side effect and advises John to drink ginger ale and avoid any foods that generally upset his stomach. John continues taking the medication and goes to the gym 4 times during the 2-week period. And once the 2 weeks has passed, he returns to the doctor's office for his follow-up appointment. So now we come to the last step of the nursing process, and we evaluate what we've done for this patient. So when John returns, the nurse asks him a series of questions about how he's been feeling. John replies that he has been having an easier time breathing and feels significantly less tired since exercising and taking the medication. The nurse marks patient condition improved on his official medical records and congratulates John on his well-being. She then advises him to remain on the medication for 1 more month and to continue his exercise. So it all worked out for John. He seems to be doing a lot better with all the implementation and nursing interventions and physicians' prescriptions and recommendations for the patient. So this just explains a little bit about putting these steps into a real life situation with the patient condition, starting with when the patient comes to the hospital or comes to the physician's office with a certain complaint. Then we, of course, start off by doing a good and complete assessment on the patient, and then making that nursing diagnosis from the information obtained during the patient interview, and then we set goals or outcomes, and then we implement that, and then evaluate what we've done for the patient to determine if what we're doing is working, or do we need to develop another care plan. And I wanted to show you too that what we provided in the syllabus are some of the possible concept-based nursing diagnoses that you may see with your patients. And for right now, being just in Nursing 121, you might see risk for alteration or alteration and elimination, or any of the concepts that we're going to talk about with Nursing 121, and these are in your syllabus. So I just wanted to kind of point that out to you. All right, what we're going to do here now is just go through some practice questions on the nursing process. And you do have these uploaded in your Canvas course, so if you want to refer back to them, these will be the types of questions you will see on Test 1. So let's go over question 1. All right. By the second post-op day, a patient has not achieved satisfactory pain relief. Based on this evaluation, what should the nurse do next according to the nursing process? So I want you to look at A, B, C, and D. and think about what your choice may be. And the answer to that question is A, reassess the patient to determine the reason for unsatisfactory pain relief. The rationale behind that is the nurse should reassess the patient to determine why he has not achieved satisfactory pain relief. Various factors may be influencing his lack of pain relief. All right, question 2. A nursing instructor is reviewing the steps of the nursing process with students. The students identified which of the following as objective data. Select all that apply. This goes back to information and previous knowledge that we learned in Nursing 100. What is the difference between objective versus subjective data? So I want you to look at A, B, C, D, E, and F and determine which of this information is objective data. And the answer to this question is A, respiratory rate of 22 per minute. D, skin pink, warm and dry. E is urine output 300 milliliters per 8 hours. And F is dressing clean, dry, and intact. This is all observable information and data from the patient. Remember, objective data are those that nurse measures and observes. Okay, question 3. A nursing instructor is reviewing which actions a nurse can initiate without a medical provider's prescription with a group of nursing students. The student should identify which of the following as nurse initiated. Again, I'll select all that apply question. So I want you to look at these choices and determine which of these the nurse can initiate without a doctor's order. The answer to this question is C, show a patient how to use progressive muscle relaxation. D, perform a daily bath after the patient's evening meal. And E, reposition a patient every 2 hours to prevent pressure ulcers. The nurse is not allowed, and under her scope of practice, to give morphine without a doctor's order, and she is not, in her scope of practice, allowed to insert an NG tube to relieve a patient's gastric distension without a doctor's orders. But she is able to do that skill, but she does need a doctor's order in order to do it. All right? So number 4, question 4, during evaluation, the nurse must gather information about the patient to, now this is the evaluation step, or the reassessment step. And of course, the answer to that is A, identify whether the patient outcomes have been met. Evaluation involves gathering information about the patient to determine whether the patient outcomes have been met. And I apologize for the misspelling of met. The A should not be there. All right, question 5. A nursing student is reporting the care given to a patient. He or she states the patient said his leg pain was back, so I checked his medical record, and he received pain medication 6 hours ago. The order reads every 4 hours PRN for pain, so I decided he needed it. I administered the medication and checked with him 40 minutes later. He stated that his pain is going away. Which step of the nursing process did the student leave out? And I also want you to think about this scenario. Did the student make a med error as well? Something else I want you to kind of think about as you read this situation. Well, what the student left out was the assessment. The student should have used the assessment step of the nursing process by asking the patient to evaluate the severity of his pain on a 0 to 10 scale. He or she should also have asked about the characteristics of the pain and assessed for any changes that may have contributed to the worsening of his pain. As we looked at that scenario, the student did not really make a med error. If we go back to that question, we can see that the order was that the medication be given every 4 hours PRN for pain. The patient had it 6 hours ago, so it was in the correct time frame, and we would assume that the student gave the correct dosage. It's not that there was an error made, but really it would have been necessary. It should have been important for the student to realize that he should have assessed that pain, looking at the pain scale and really finding out more about the characteristics of that pain. Was this a new type of pain? Was it in the same spot as the pain he had prior to being medicated for pain? That is really, really important information. And many times it's not even necessary that the patient receive a medication to relieve the pain. Maybe it could be that the patient just needed repositioning. So that's why that piece of the nursing process is so important, to make that really, really good assessment on the patient when he complains about something. So that is just a few examples of questions that pertain to the nursing process. And again, you might see these similar questions on your first test. I hope you feel comfortable about your knowledge pertaining to the nursing process. Be sure that you have read the assigned reading so that it makes sense, that you understand all the steps. And again, make that correlation with the concept maps that we've been doing, which were taught to you back in Nursing 100. If you have any questions about the nursing process, please let me know. Hopefully, with the videos and the PowerPoint and the practice questions, you understand the importance of how the nursing process really does guide us in the beginning that assessment process. So now we're going to switch gears and talk about our second exemplar, the 5 rights of delegation. And again, I have a Pearson video that I would like you to watch, and then we'll go over a PowerPoint as well.
Focus on more complex patient care needs. It also develops skills of assistive personnel and helps contain costs for healthcare organizations. According to the National Council of State Boards of Nursing, UAP, also referred to as NAP or Nursing Assistive Personnel, are any unlicensed personnel, regardless of title, to whom nursing tasks are delegated. UAP have many job titles. Some of the more common ones are nurses' aides, certified nursing assistants, and patient care technicians. The delegating nurse must know the job description and match the skill level of the UAP to the task being delegated. Training and experience are both important factors in deciding which UAP can safely perform a task. Practice acts and regulations about delegating vary by state. The licensed nurse is ultimately responsible for the nursing care that is delegated. The UAP who receives the delegated task may not delegate it to another person. Delegation decision-making is part of the planning phase of the nursing process. Client protection is the fundamental principle when making the decision to delegate. Delegation includes all of the following elements. Evidence-based practice, creating a scientific basis for nursing decisions. Boards of nursing, which write guidelines for delegation decisions. State practice acts that create regulations. Licensed nurses who are accountable for the nursing care provided. Policymaking and procedures related to delegating. Ensuring that standards of care are met when delegated tasks are performed. Utilizing UAP who help nurses provide complete nursing care to the client. UAP assists nurses. They do not replace them. The 5 rights of delegation address crucial elements in decision-making about delegation. Delegation increases the scope of liability for licensed nurses. Nurses are not directly liable for acts of negligence by UAP. However, if they are directly supervising a delegated act, when the UAP commits a negligent act, they may also be held liable. The first delegation right is the right task. When deciding which tasks can be delegated, nurses generally include tasks that occur often in daily care, tasks with predictable results and minimal risk, tasks with an unchanging procedure, tasks that do not require nursing knowledge and professional judgment, or complex application of the nursing process. Only nursing interventions can be delegated. Examples of appropriate tasks for delegation are taking vital signs, helping clients with transfers and ambulation, bathing, feeding, and bed making. Tasks that cannot be delegated are essential functions of nursing, such as interpreting data and creating care plans. Skilled nursing tasks, like administering parenteral medications, also should not be delegated. The right circumstances for delegation require nurses to assess the client's health status, analyze the data, and identify specific goals and nursing needs. The nurse must be aware of resources, matching the complexity of the activity with UAP competency and the level of supervision available. Delegation is based on the client's needs and goals at the present time. When the client's condition changes, the nurse must reevaluate nursing care needs and adjust the tasks that are delegated. The right person aspect of delegating means that nurses must be sure UAP are competent and understand the task related to the particular client. Nurses must be sure that they themselves understand and maintain professional standards. Nurses must evaluate UAP performance and take steps to remedy failure to meet accepted standards. Even if a task can legally be delegated, the nurse must still determine if the task can be delegated to a specific UAP, caring for a specific client. Right directions or communication can be oral or written. Stating specific data to be collected, the method of collection, and timelines for reporting. Providing directions and clear expectations of how the activities are to be performed. Naming the expected results or potential complications, including a timeline for reporting back about them. Right supervision means that delegating nurses must monitor and evaluate the performance of specific nursing activities or assign supervision to another licensed nurse. To supervise directly, the nurse might monitor the UAP's performance, obtain and provide feedback, intervene if necessary, and ensure proper documentation. The delegator may also supervise the delegation process indirectly by evaluating the client after the activity has been performed. There are some common delegation errors. Underdelegation may stem from lack of trust in UAP. It may also occur when nurses think they should be able to do the whole job by themselves. Overdelegation is a second common delegation error. Some managers overdelegate because they are insecure about their own ability to perform a task. Others do not take time to organize work efficiently. In either case, overdelegation increases stress and can decrease productivity among staff. Improper delegation includes delegating tasks at the wrong time, to the wrong person, or for the wrong reason. It includes delegating tasks and responsibilities that are beyond the ability or scope of the person to whom they are being assigned. Several tools are available to guide the nurse through decision-making about delegation. Decision grids and decision trees can be found in a variety of nursing textbooks or on the ANA or National Council of State Boards of Nursing websites. Supervisors or mentors can also be a source of guidance and direction when considering decisions about delegation. Delegation of tasks to UAP is essential to ensure that all necessary nursing care of clients takes place. If appropriate guidelines are followed, delegation to UAP can be a reasonable, safe, and resource-efficient method of extending nursing care. Delegation empowers UAP, builds trust and efficiency, and strengthens healthcare teams.
Before we continue with this delegation PowerPoint, a couple things I want to just kind of talk about. First of all, when we talk about delegation, you as a nurse should always realize that we never delegate to family members or friends of our patients, okay? Sometimes spouses will offer to assist their loved one with a bath or something. But we as nurses would never say to a patient's family or to a friend, I need you to bathe your husband today because we're short-staffed, and I would want to make sure that this patient got his hygiene given to him today. No, we would never do that with a family member or a friend or client. Again, it's important to know what task may be delegated and tasks that may not be delegated. Anytime it requires scientific and nursing knowledge, that is something that would tell you that is not something you're able to delegate to, okay? And that would be an assessment, any type of interpretation of data, or even creating a new nursing care plan. There are benefits for the nurse with delegation. It frees her up to spend more time with jobs that only she can do. An example of that she would never delegate central line dressings to a UAP. That would be something she can only do. But she sure could ask the UAP to assist Mrs. Jones up to the bathroom because she called and said she had to use the restroom. And there are benefits to the delegate as well when we do it in the correct way. Like I said, this is a very hard skill to be comfortable with. I know I have a hard time with delegating. I always like to just do things myself, and that probably comes from the fact that I've always done primary care nursing, where I always took full care of the patient and didn't have to delegate for like a UAP to do my vital signs. So maybe that's where I feel not always so comfortable in delegation. But there is a lot of benefit to the person that you're asking to do a particular task. They can gain new skills. They realize that you as the nurse trusts and supports them. It increases their self-esteem and their confidence. It also produces job satisfaction, and it motivates them to be a very good member of the healthcare team, to provide that good team, because good care to the patient, because it really does take a good group of very dedicated and professional people to provide that excellent care that we know we should be giving our patients. Plus their morale improves and they feel appreciated and feel valued, and that's what we need to do when we're working. And it really presents for a very positive working environment. I mean, people enjoy and want to come to work when you're appreciated and valued. There's benefits to a manager. The unit will function better, and her job as a manager, where she can only do management tasks, those can get done as well, and it benefits the organization. Teamwork improves, the quality of care improves, and of course it increases and improves patient satisfaction. So again, the delegation process is defining the task, decide on the delegate, describing the task, reach an agreement, and monitor their performance and provide feedback. It's nice to go to somebody and say, hey, I just want you to know, boy, you really did a nice job in that particular patient's room, and the patient looked so good, and I just want to commend you on really stepping up and doing such a great job when I really got tied up with another patient. Let people know that they're doing a good job, and then if you're not sure about some people's performance, this is when you have to go back and be sure that things are doing that are being done correctly. That's also your responsibility, and to be accountable to be sure that those patients are getting the care and the treatments that are supposed to be delivered to the patients as well. Another thing I wanted to talk about was there are factors that definitely affect a delegation. Assignment patterns, where you have unit-based healthcare teams, and pairing, which is one of the most effective means of delegation, and partnering is another best way to be sure that the jobs are getting done and the tasks are getting done. Accepting delegation. If you've got somebody that's being a little bit being a little bit difficult to work with, and you might delegate a task to them. If they refuse to do it because they feel like they're too busy, those are things that definitely affect delegation and kind of give you a little bit of some leeriness and weariness in the fact that maybe I'm not delegating correctly, especially if someone that's very hard to work with. Be sure that they understand the task. You have to be very specific and say to that person, hey, I need you to go in there right now and take a blood pressure, and I want you to get that information back to me as soon as possible, because I have some medications that I have to give the patient, and I want to be sure that his blood pressure is okay. So I need that information as soon as possible. Because if you just tell somebody to go get a blood pressure and you don't give a time frame, they might say, hey, it's not something I have to do right now, and may really wait to do it at a further time, where you're expecting that person to come back with that data for you, and they just misinterpreted what you were asking them to do. So be very specific when you delegate a task to somebody, that you explain exactly what you want done and when you want that information to come back to you. Obstacles to delegation, non-supportive environment, lack of resources and not enough staff, and time resources. And the delegator can feel very insecure about this particular skill as a nurse, because of fear of competition, fear of liability. Oh, I'm really worried about giving this task to so-and-so, because what happens if they don't do it correctly and something happens with the patient? I don't want to feel like I'm responsible. Fear of loss of control, fear of overburdening, and fear that others will be dissatisfied with their job. And so these are things that the delegator thinks about when they're deciding on what task to delegate and to what person to delegate to. So let's go over this PowerPoint, and then we'll look at another video, and then go over some, I will do an activity and go over some questions as well about delegation. And this PowerPoint is pretty much a review of what we saw in the Pearson video. Again, delegation is a transference of responsibility and authority to competent individuals, and as the delegate, they assume responsibility, and as the delegator, they assign a task, but still retain accountability. Delegator can devote time to other tasks that only he or she can do, and it increases skills and abilities of the delegate, of the person that you delegate that task to. The principles of delegation: RNs increasingly delegate components to other RNs, LPNs to nurse extenders, unlicensed assistant personnel, certified nursing aides or assistants, home health aides, client care technician, orderly or surgical technician. These are the tasks that can be delegated: vital signs, INO, patient transfers, ambulation, postmortem care, bathing, feeding, and sometimes in some facilities, gastrostomy feedings in established systems. A feeding that has already been there for a long period of time. An additional task that can be delegated: attending to safety, weighing the patient, performing simple dressing changes, suctioning of a chronic tracheostomy, a trach that's been there for a long time, or even just performing basic life support. Get your UAPs involved if there's a rapid response or something that requires a code situation and requires a patient to have CPR done. Give them that experience to know what it's like to do CPR on a real life person. These are tasks that cannot be delegated: assessment, interpreting data, making a nursing diagnosis, creating a nursing care plan, and evaluating care effectiveness. You can see that these all have a lot in common, as the fact that it requires nursing knowledge to be able to do these types of tasks, and these are things that cannot be delegated. Care of invasive lines, administering parenteral medications, inserting NG tubes, client education, performing triage, and giving telephone advice. And these are the principles of delegation: delegating to unlicensed assisted personnel. Nurses must assess first. Client medically stable or chronic. Tasks must be considered routine for this client, not required substantial scientific knowledge. Technical skills be considered safe for this client and have predictable outcomes. And when the nurse is delegating to a UAP, the nurse must obviously learn agency policies and know their scope of practice. What can I delegate to this UAP? And be aware of the variation in ability. Even though it's in their scope of practice, for instance, to do postmortem care, if the UAP has never done that before, it might be a time when you might assist the UAP to kind of show them how this skill is done, so that the next time the situation arises, they will have had the experience to do that, and it just showed that you cared enough about that person to kind of support them when they're doing something for the very first time. Observe if unsure of abilities and clarify reporting expectations, and definitely create a positive atmosphere. It's really about the delivery of how you ask a certain healthcare team member to do a task. Again, showing respect and making that person feel valued as well. Delegating to those unlicensed assistant personnel. Must understand for each client the task to be done, when task is to be done, expected outcome, who is available, and when and in what format report expected, and what the specific tasks are. Differentiating delegation from assignment. Delegation transfers responsibility and authority. Assignment, no transfer of authority, and reflects job descriptions and client needs and organizational needs as well. Now, I talked about delegation versus dumping. Delegate because it is best use of time and not an undesirable task, and it provides the greatest benefit to the client. It provides delegates with opportunity for growth and increasing skills. And I think this is where experience comes in, so that we know that we're not overburdening the people that we're working with. It's very upsetting to UAPs or PCNAs or whatever we want to call them when we are just getting dumped on with more and more things to do, and the RN is sitting at the desk socializing or chit-chatting with the doctor, or maybe on her personal cell phone, or she's on the computer doing her shopping. This is when you start to see a a very toxic environment, and this is where resentment sets in. So this is where we don't want to see these kinds of things happen, that the delegate feels that she's not being taken advantage of, and that her time and her level of expertise is being respected as well. And as I said before, there are benefits of delegation to the nurse, more time for complex client care. Maybe this gives the nurse time to go in there and do some teaching with the patient. And again, for the delegate, allows delegates to gain new skills, abilities, and it starts building that trust and support between the nurse and the UAP. There are benefits to the manager, more time for tasks that cannot be delegated, where she can tend to her managerial jobs, and benefits to the organization. Overtime decreases, absences decrease, and of course productivity increases. And of course we see that the patients are much more well cared for, and increased patient satisfaction scores also increase as well. And then again, here's just a reminder of the 5 rights of delegation: the right task, the right circumstance, the right person, the right direction and communication, and the right supervision. So I hope this answers a lot of your questions about delegation. I'm going to show you a video of how delegation went very wrong, and then we'll do some question and answer in just a few minutes. All right. Good job, everyone. I hope you're staying focused and enjoying our time together as we go through these exemplars pertaining to our concept of leadership.